This video is on layers of scalp. Each layer of scalp has got its clinical significance. We will find some answers to clinical anatomy questions in this video, such as why scalp wounds they bleed profusely but heal also faster. Why deep wounds of the scalp, some of those wounds, they tend to gape. Which is the dangerous layer of the scalp, and a blow on head, how can it cause black eye? So these are the answers you'll find in this video. So let us begin with the layers of the scalp. Now to remember the layers of the scalp, the mnemonic is itself the word scalp. If we look at this, scalp has got 5 letters. Each letter stands for one of the layers of the scalp. So in this slide, we will just see what are the 5 layers, and these are, so the superficial most layer, that will be obviously skin. So we can see here, this is the skin. Then second layer is the connective tissue layer starting with C, and this is also the superficial fascia of the scalp. The third layer begins with A letter, and this is aponeurosis, right? So as the name suggests, aponeurosis, there has to be some muscle also. The muscle here is the occipitofrontalis muscle and its aponeurosis. The aponeurosis is a very big aponeurosis here in this case. So that's why it is mainly known as aponeurotic layer. Then the fourth layer will start with the letter L, and this is, we can see here, loose areolar tissue. And the deepest layer, right, that is the pericranium. This pericranium is nothing but the periosteum of the skull bones, which are seen here. So let us see all the layers now, from the deep to the superficial. Let us see that now. So here we can see this is the brain. Then brain is enclosed in meninges, and then this is the skull bone, and skull bone outside there we have the periosteum. That periosteum itself is called as the pericranium. So the deepest layer is pericranium. Then we have the loose areolar tissue. Next to that is the aponeurosis. Next is the connective tissue, also the superficial fascia of scalp, and the superficial most layer is the skin. So these are the 5 layers: skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. Let us look at some of the details of each layer and their clinical significance now. Starting with the skin. So here we can see this layer is the skin. What is special about the skin of the scalp? We can all know that it has got lots and lots of hair. So obviously there will be lots of hair follicles also. The skin of scalp is not very thin. It is thick, right? And it has got hair, lots of hair, plus it has got lots of sweat glands, and it has also got the sebaceous glands which are associated with the hair follicles. So here we can see this is the hair coming out, these are the hair follicles, and we can see here the sebaceous glands. So what happens, because of these large number of sebaceous glands which are present in the scalp is in fact the commonest site of sebaceous cyst. So these will appear on the scalp as small bumps, you can see, filled with the secretions there. And what happens here is that sebaceous glands, they produce a lipid rich substance known as sebum, and because of some infection, if their drainage is blocked, right, so that will lead to accumulation of that, and they will form the sebaceous cyst which look like this on the scalp. So that is skin. Skin is thick, hairy, lots of which glands? Sweat as well as sebaceous gland, and commonest site of sebaceous cyst. Next layer is the connective tissue layer, which can be seen here. Now this connective tissue or the superficial fascia, here it is not very loosely arranged connective tissue. This is quite dense. And another important feature of this is that we have actually certain septa which will be going from the skin to the underlying aponeurosis. So these green septa which you see, they are extending between the skin and the aponeurosis, and they firmly attach the skin to the underlying aponeurosis. That is first thing. The second thing is, because of these number of these septa, what happens? This layer gets separated into small pockets. These small pockets will be containing the fat there, plus the main blood vessels, the named blood vessels which will supply the scalp, and the nerves will be passing through this. So fibrous septa, which are extending from the skin to the aponeurosis, they break this layer into numerous small pockets. And because of this, if there is any infection there, the unyielding nature of these fibrous septa will result in painful condition, right? Because the nerves which are passing through, they will be stimulated. Okay, so next thing about this layer is that they have got these blood vessels passing through that, right? Now let us see why wounds of scalp, they bleed profusely. First thing, scalp has got very rich blood supply, so that is one reason. But the second is, the more important reason is that these blood vessels, if we look at this area here, the walls of the blood vessels, they are attached to the network of the fibrous septa here within these small pockets. So as a result, if suppose this blood vessel is cut, right, so its wall will not be able to retract or collapse and stop the bleeding, because the lumen will remain open. The wall is attached to fibrous septa. बाहर अगर किसी सर्कमफ्रेंस पे बहुत सारी तारें लगी हुई हैं और वो तारें कहीं और जाके अटैच हुई है, सो क्या होगा, दे विल नॉट लेट दैट luminal structure to collapse. So this is what happens here also. So the vessels will remain open, the lumen will remain open, and that's why the wounds will bleed profusely. So here the main reason for that is that the walls of the blood vessels passing through the second layer, they are attached to the fibrous network in the second layer and are unable to retract, and this causes profuse bleeding. Third layer, which is aponeurosis, it is also known as epicranial aponeurosis, above the cranium epicranial. Galea aponeurotica. Galea means helmet. It kinds of form a helmet over the head, so that's why galea aponeurotica. As I said, aponeurosis has to be associated with the muscle, right? Muscle has can be inserted or can take origin either from the tendon, right, via tendon, or via the aponeurosis. So actually muscle is, if you look at the muscle, this is enclosed in, you must have seen endomysium, perimysium, right? And these connective tissue layers which are present, which are surrounding the muscle, so they, when they collect at the end, they can either form a cord-like structure, which is known as tendon, that can be attached to bone, or these connective tissue sheets which are covering the muscle, that is the endomysium, the perimysium, and the epimysium, these layers, right? They might be present in the form of a flat sheet, and then you call it an aponeurosis. So this is what happens in case of the muscle of the scalp, and the muscle of the scalp is occipitofrontalis muscle. As the name suggests, the muscle will be extending from the frontal region till the occipital region, right? So how it is present? The muscle has got four bellies, two in front or anteriorly, these are known as frontal bellies, two are present posteriorly, known as occipital belly. Now let us look at the frontal belly. The frontal bellies, which we see here, they do not have bony attachment. They do not have bony attachment. So they are taking origin from the skin, over the eyebrows, and over the root of the nose. These are the superficial fibers of the frontalis belly. The deeper fibers, they are going to merge with the muscles here, and these muscles, three muscles are the procerus, the corrugator supercilii, and this muscle, circular muscle, which you can see here, orbicularis oculi, like an orbit around the eye, oculi, orbicularis oculi. So frontal belly has no attachment, okay? It is taking origin from skin, subcutaneous tissue, over eyebrow, root of nose, and deep fibers are attached to these muscles. Now, where is it inserted? The frontal bellies are broad here. You can see very little aponeurosis can be seen between them. They actually almost are adjacent to each other, the two bellies. Posteriorly, they will be inserted into epicranial aponeurosis. Let us look at the occipital bellies. The occipital bellies, you can see, are widely separated from each other, and in between also we have the epicranial aponeurosis. They take origin from these lines present on the occipital bone, which are known as superior nuchal line. Nuchal means neck. So these lines are separating the head from the neck. So superior nuchal line. Which part of the superior nuchal line? The lateral 2/3 of the superior nuchal line, because to the medial 1/3 we can see here the epicranial aponeurosis that would be attached. So these are the occipital bellies. They are smaller also. They are widely separated from each other also, and they also will be attached to which structure? The epicranial aponeurosis. So you have two frontal bellies in front, no bony attachment. Two behind, which are attached to the superior nuchal line, and both of these, they are inserted into the epicranial aponeurosis. On the side, actually it cannot be seen here, but this epicranial aponeurosis will be attached to superior temporal lines. Okay, so this is about this aponeurosis, which can be sorry, which can be seen as a green thick layer which is present here. So this is the third layer. Now, why deep wounds of scalp gape? Deep wounds of scalp will gape if the epicranial aponeurosis is cut, and in which direction it is cut? If it is cut transversely, not vertically, right? So if there's a transverse cut in the epicranial aponeurosis, it will tend to gape. There will be a gap between the two ends of the cut, right? So why this happens is because here the frontal belly will pull this part of the aponeurosis anteriorly, and the occipital belly will pull it posteriorly, because there is a resting muscle tone in these muscles, all the muscles, right? So that resting tone of the muscles, even if they are not, you are not contracting them consciously, that tone, resting tone, will pull the two cuts, the two edges of the cuts anteriorly and posteriorly respectively. So because of this, the wounds tend to gape if there is a cut in the epicranial aponeurosis transversely. Now that's why these kind of wounds, they need to be sutured if the healing has to take place. Coming to fourth layer, a very important layer. This is the loose areolar tissue layer, which we can see here. This is present here. This is the fourth layer, right? So this is actually so loosely the connective tissue is present there. This is a potential space. What happens if there is any kind of infection in the scalp? Then the pus will accumulate in this layer, because there is a lot of loose space present there. If their blood vessels are cut, there will be accumulation of the blood also in this layer. Now the upper three layers which you see here, that is skin, the connective tissue and the aponeurosis, these three layers are known as the surgical layers. So when the surgeon wants to actually give or has to cut through the cranial bones to reach the cranial cavity to perform any surgery, then this fourth layer acts as a cleavage, right? These three layers are firmly attached, so they cannot be separated from each other. So this acts as a cleavage during craniotomy, and the surgeon is going to reflect all the three layers together. Now suppose someone's hair that gets caught in a machine. So all these three layers, they will be actually avulsed together, okay? And these three layers are also known as surgical layers of the scalp. So first thing is this here, the loose areolar tissue. This layer acts as a plane of cleavage during craniotomy, when the surgeon has to perform the surgery on the cranial structures present in the cranial cavity, that is brain. Next, it is obvious I'm dealing with the fourth layer here. So which layer is known as dangerous layer of scalp and why, right? It is the fourth layer of the scalp which is known as the dangerous layer. This is the fourth layer. Now why it becomes dangerous? Why something will become dangerous? Something becomes dangerous if suppose the infection which is present outside, right, of the cranial cavity gets inside. You hardly have any lymphatics there to protect you, right? So any infection which is present inside the cranial cavity can become very dangerous, right? So how this happens here? The fourth layer actually contains or has got these veins which traverse through this. These veins are known as emissary veins. What are the emissary veins? Emissary veins are those veins which connect the veins which are present outside the cranial cavity, that is extracranial veins, with the intracranial dural venous sinuses. Within the dura mater, you have venous channels known as dural venous sinuses, right? So those are emissary vein. So in case of scalp also, what will happen? The veins of the scalp which are present here in the second layer, they will be connected to the emissary vein, and on the other hand, within the cranial cavity, this green layer is the dura mater, which has got two layers here, endosteal and the meningeal. So you can see this venous channel, the dural venous sinus. This emissary vein is connected to this, and there are no valves here, right? So the blood can flow in any direction. So if there is infection here, right, that can pass from the veins of the scalp through the emissary vein to the dural venous sinus and can lead to meningitis. It can involve the brain also, right, within the cranial cavity. So that's why it becomes dangerous. So fourth layer is known as the dangerous layer of scalp, and this comes as a short note also in exams. So infection from this layer may travel along emissary veins from scalp to dural venous sinuses. That's why it is known as dangerous layer of scalp. There is another phenomena, that is black eye phenomena, that occurs, right? Obviously there will be a black eye if somebody punches in the eye itself. There will be hematoma formed in over the eyelids, right? But in case there is a blow on the head, right, not on the eye, then also after few hours it is seen that there is black discoloration over the eyelid and accumulation of blood here, right? The hematoma is there, and this is known as black eye. So a blow head on head can also cause black eye. To understand, let us look at this diagram. This is a sagittal section from a part of the head region, and what do you see here? This will be the skin, then there will be superficial fascia, then this is the epicranial aponeurosis, and this muscle which you see here, this is the frontalis muscle. And then we have the fourth layer, and after that we have the skull bones covered by pericranium. Now, if we look at this frontalis muscle, I have already told you this has got no bony attachment anteriorly. It is taking origin from skin and the subcutaneous tissue over the eyebrows, right? And the deep layer merges with the orbicularis oculi muscle. So that means anteriorly the fourth layer becomes continuous with the space here in the upper eyelid, right? And the reason is because frontalis has got no bony attachment. If it had bony attachment, it would be attached here to the frontal bone. Then what will happen? Anteriorly, the fourth layer will become, that will be blocked there. But that has not happened in this case. Frontalis has no bony attachment, and because of this, the fourth layer of scalp becomes continuous with the space in the upper eyelid. This is the superior tarsal there. So let us see what happens here. Suppose there is blood vessels are cut and the blood is accumulated in the fourth layer. Now what happens when you're sitting, when you're standing? Because of the gravity, this blood is going to trickle down or gravitate along the fourth layer into the eyelids. First upper eyelid, and later on it will go around to the lower eyelid also, and this will lead to black eye. Let us again understand this via flow chart. Blow on head leads to collection of blood in which layer? Fourth layer, right? Then second is blood gravitates into the eyelids because frontalis has no bony attachment, frontalis. This is the main reason. And there is formation of hematoma and black eye discoloration of skin around the eyes approximately few hours after the head injury. Now I have seen some of the students, they get confused. In dangerous layer of scalp, they write black eye. Black eye is not dangerous, right? So black eye is different. This also involves fourth layer, but the dangerous layer is because infection can travel from the veins of the scalp, from the scalp into the intracranial dural venous sinuses, right? That is the reason for dangerous layer. So you must remember these 2 points about the fourth layer. Coming to the last layer. The last, or not before the last layer, let me explain this also. The blood only goes anteriorly into the eyebrows. It cannot go laterally or it cannot go posteriorly. Why is it so? It happens because laterally the epicranial aponeurosis is attached to superior temporal line. So it will be restricted to the fourth layer only of the scalp laterally. Posteriorly also, if we see here, these are the occipital bellies, this is the epicranial aponeurosis. Where are they attached? They are attached to superior nuchal line, and this aponeurosis is also attached to a bony prominence here known as the external occipital protuberance. This is known as external occipital protuberance. So here posteriorly also you don't have any opening here through which the blood can pass into the neck, right? So the blood will only pass anteriorly, neither laterally nor posteriorly because of attachment of epicranial aponeurosis to superior temporal lines, and the occipital belly and epicranial aponeurosis to the superior nuchal lines. Last layer is the pericranium, which you can see here, right? This is nothing but periosteum of bones of the skull cap. You must have studied in general anatomy that the bone has got an outer fibrous and cellular layer known as periosteum and inner layer which is known as endosteum. So the periosteum of the skull cap bones here, like the parietal bone in this case, that is known as pericranium, right? So now this pericranium is loosely attached all around the bone. It can be easily stripped off from the bone, but it is firmly attached along the sutures. These are the sutures you can see. So this parietal bone is separated from the frontal bone here via this suture, or not separated, we can see they are forming a joint here, right, which is known as sutural joint. And here we can see this is the parietal bone and this is the temporal bone. Here again parietal bone and the occipital bone, and in between we have these fibrous joints which are known as sutures, right? So what happens is this the periosteum, which we call as pericranium, this actually will be firmly attached along these sutures to the endocranium, right? How? Because through these sutures we have some fibrous tissue known as sutural ligaments. So outside we have pericranium, inside we have endocranium, and between in the suture there is fibrous tissue known as sutural ligaments, right? So they are connected on outside to pericranium and on inside to the endocranium, right? So this here they will be, the pericranium will be firmly attached. This holds true for other bones also. So because of this, what happens? Now, as I said, this layer pericranium can be easily stripped off from the surface of the bone itself, right? So there is a condition known as cephalhematoma. So here we have, this is the cephalhematoma. Let us see here in this coronal section. This would be skin and superficial fascia here. This blue structure is the epicranial aponeurosis. Then there is a dark line there which is pericranium. And here we have the bone. So now this cephalhematoma is the hematoma which is formed between the pericranium and the outer surface of the skull bone. Now this is going to take the shape of the bone itself, and most of the time it involves the parietal bone. So this hematoma will be taking the shape of the parietal bone. So why this happens here? So what exactly is cephalhematoma? It is accumulation of blood deep to the pericranium. The swelling takes the shape of the bone involved. Why this happens? I've already told you why it happens, because pericranium is loosely attached over the bone, but here you can see some brown colored lines here, right? These are the places of the sutures, and these brown things, these are the sutural ligaments. So here the pericranium will be attached to the endocranium via the sutural ligaments, so blood cannot pass beyond this. Okay, so that's why cephalhematoma will take the shape of the bone over which it lies. And where is the accumulation of blood? Between the pericranium and the bone of the skull. So that's all for this video. Thanks for watching. And if you have not subscribed, please subscribe my channel so that I can put more such videos. And if you want the questions and answers in anatomy, all types of that, then visit the website, that is anatomyqa.com. Thanks once again.